get into this, we did every persona, and we even threw in one unnecessary perpetrator. Yeah, this just gives you an idea of thinking about how broad the patients are in an A&E department, that it can be anyone and everyone. It is slightly stereotyping or profiling, but it's also looking at understanding their situation in life and how an unfamiliar environment can affect someone with some sort of mental state or disability.
Okay, so as we come to the end of the second stage, the define stage, we've now completed our own fieldwork and research to familiarize ourselves with the A&E environment and process. So in the define stage, we needed to carry out our own research in order to understand the A&E service as it currently existed. It was important to us to get a comprehensive understanding of the process for patients, who the potential perpetrators were, and also the staff perspectives. And our research provided us with a good foundation to begin the design work. So the next stage on the double diamond process is the develop phase. We took the refined intent distilled from the various research, both from the Design Council and our own research, and use it as a basis to create a set of design solutions. So the main objectives on this develop phase, developing the initial brief into both a product or a service for implementation, design service components in detail and as part of a holistic experience, and iteratively test concepts with end users. So now we're ready to begin really designing. So as we move on to the next stage, we had to understand what the designs needed to be achieved. The requirements stated the design needed to be easily implementable, non-trust specific, retrofitable, flexible, affordable, and effective. So this stage is where the design really begins to happen. In these images, you can see that the beginnings of our design process. We had to visualize our research and sift through all the information to see what has the most potential to move the design forward. So as a start, we really focused on the ideal patient experience. We were looking at different aspects of the patient journey and what elements could be introduced to provide patients with a better overall experience. So this was to really understand how complicated the system can seem to anyone who has a lower threshold in the A&E environment. We realized that more information and transparency about the patient journey would be beneficial to every service users. So this discovery encouraged us to focus on how information could be delivered to the patient and how it could be better communicated to users and what ways we could do that, we could show that. So therefore, we needed to break down the patient journey into key stages and a description of what happens at every stage.
So whilst we did this mapping of the patient journey, it became very clear that this would be useful information for everyone visiting A&E departments. So our design focus really shifted into making this as clear as possible and to have a strong graphic impact that would become the foundation of our design solutions. So over the next few slides, we're going to show you how we broke down the patient journey and the many iterations that we went through of this. So as you can see here, we really were looking at how to readdress perceptions around waiting in A&E. So it was important to illustrate the wait as being a part of the patient journey throughout their treatment. It was also important for us to show how patients who arrived by walking in followed the exact same process as those who arrived by ambulance. And we experimented with colors and icons and layouts to understand what was easier to read and how to be clearly understood from a very quick glance. So in this version, we really simplified the layout and played with various shades of the same color to make the hierarchy stand out, but also not be too in your face. And it was quite important for us, for patients, to know what staff member they would be talking to at each stage. So we started developing icons for each of the stages. And we used user testing to help inform and develop these so that they were easy to read and understand, but also communicated the right message. So this version of the process map is very close to our final version. Here you can see that we streamlined the 4 stages. We added more hierarchy, something that could be read from a distance, but we also thought it would be useful to have a bit more information about the various treatment areas and have some text on there. And to ensure that this information was communicated throughout the department, we wanted to visualize how it could be installed throughout the department as a whole, not just in the arrival area. And as you can see, we have different information points represented by these blue cubes, and we wanted to make these the recognized information point for patients as they progress through the department. And we wanted these to be various shapes and sizes, but also have appropriate information at that stage of care. So we began looking at that in detail as to how these could be treated in different areas of the hospital, such as in the waiting room, having the process map quite large and to catch people's attention, but also having it interspersed throughout the department and catching people's attention, but still having adequate information. We were also looking at the full scope of this, so how would these signs be implemented outside the hospital, in reception, and also in the treatment areas, as well as in staff areas, and could this information be mobile as well? Could it be something that patients could take with them? So because of that, we thought it'd be quite important to develop a patient leaflet. So this leaflet has the 4 key stages on it and information about what to expect in each stage. So this is something that could be handed to patients when they check in, and they could take it with them as they progress through the department so that they could refer back to it at any point. Developing a solution for patients was only half of our problem. We also needed to develop solutions that focused on the staff perspective. And to do that, we looked at a process that used reflection, learning, and reporting for these incidents of violence and aggression so that staff could recover from this, but also learn from these incidents and understand maybe what measures they could take that could hopefully mitigate these incidents from occurring. As we were doing this, we realized staff actually didn't have very much information about who these perpetrators were. And by recognizing these profiles, they could, and warning signs of the perpetrators, we thought it would be quite useful for staff to have, and how they could deal with these patients. And through that, we created cards and information regarding these perpetrators and actions that they could take that could better deal with these personalities and issues that would help keep them calm. And we also developed a staff handbook that offers guidance and suggestions on how to better deal with their patients and would hopefully alleviate any unnecessary incidents from occurring. And it was more about giving staff adequate information when they arrive at the hospital and go through training, rather than having an incident happen and not sure what the appropriate protocols were. And since acts of violence and aggression were still very likely to occur, we knew it was important for staff to realize that they shouldn't expect this kind of treatment in their workplace, and that it was perfectly acceptable to note and report when these incidents occurred. But it was also important for them to realize that they're not the only ones affected by such incidents. So it was also how to have a non-judgmental environment where they could discuss these incidents and deal with them in a proactive manner. And we wanted staff to achieve a better understanding of when, where, and from who these incidents were occurring. So we developed a staff incident tally board so people could note these incidents and look at various factors such as day or night or male and female, so they could have a better understanding as to, I guess, to focus in on maybe where the problem areas were or who they were, and just to have more insight into it. So this concludes our develop stage. So we've really developed our solutions, and our ideas have taken shape and gone through numerous iterations. And now we're ready to finalize our designs, which brings us to the deliver stage. So in this stage, we needed to take the product or service to launch. We also needed to ensure customer feedback and that mechanisms were in place, and share lessons from our development process back to the organization, so back to the Department of Health, the Design Council, as well as the partner trusts. So this stage is ongoing as we are still implementing the designs in various hospitals and currently refining our solutions as necessary. Some of the tools we used were implementation. So this was the implementation of our final design solutions. We also evaluated our solutions and distributed the conclusions. So as we transitioned from developing our solutions into delivering a final design, we needed to refine what we were actually offering to trusts. And the final result was a 3-pronged set of design solutions focusing on the very different needs of patients and staff. So the solutions are the guidance solution and people solution, which are available for purchase and implementation at any trust. And we also developed a Toolkit, which is a free online resource for trusts or any healthcare providers. The guidance solution is a communication package that provides key information to patients and visitors as they progress through the department. It addresses many of the associated frustrations and anxieties previously identified as triggers of violence and aggression. It comprises a range of static and dynamic information as well as fixed and mobile. So we have a process map, panels, and a patient leaflet, as well as live, up-to-date digital information. As you'll recall from the develop stage, we were focusing on the key stages of the patient journey. So the final 4 stages that we got to were check-in, assessment, treatment, and outcome. These are the final icons that we used. They were found to be quite simple and easy to understand, and we also thought yellow was quite a good color to catch people's attention. So these icons are placed large scale on the process map, and the process map underpins the guidance solution. So it is displayed large scale in waiting areas, so it should be one of the first things patients see upon arriving in A&E. And it displays the patient journey as a series of stages with stops along the way, including waiting. In addition to the process map, we have a series of panels. These correspond to, these are installed in every room, waiting area, or corridor where a patient finds themselves. And they ensure that patients always know where they are in the process and have the most important information readily available to them, such as where they are, who should be treating them, why they might be waiting, and what to expect in that stage. And you can also see in the bottom, we have the 4 icons from the process map, small scale with the current stage highlighted in yellow. So this is for patients to always know where they are in the overall process. So the panels correspond to the various stages of care as outlined on the process map. And they contain relevant information to the patient at that stage of care. So from check-in to assessment, all the way to tests and treatments. So panels are the recognized information point for patients throughout the department, and they're customizable, so they accurately reflect the process of each trust. So when we implement it, we give these to the department, we refine the text and make sure it has anything and everything that they feel like they need to stay at that stage, because although the general process is the same, it obviously is very different from trust to trust. We chose a graphic style that was intentionally unhospital-like, something that was quite friendly and could catch people's attention, but also the colors were chosen so that they provided the right contrast and were in compliance with the Disability Discrimination Act, so that people who have some sort of visual impairment could easily read them. The second strand of the solutions works with frontline A&E staff through a reflective program called the People Solution. So it provides a forum for staff to consider without blame the factors that influence their interactions with frustrated, aggressive, and sometimes violent patients. So the program encourages a group of A&E staff members representing a cross-section of the department. So receptionists to nurses to consultants to meet regularly and discuss the factors that undermine the staff and their capacity to care for patients. The goal of it is to identify factors that impact on the collective mood and to work to remove the root causes of these incidents. Staff are asked to observe potential threats and behaviors and the causes of violence. But the reason for this is for them to learn from this and also to make changes that could hopefully better attend to patients' human needs, which are often forgotten because staff are they're very busy. They see hundreds of patients a day, and their mindset is generally to treat patients as quickly and as efficiently as possible, when oftentimes, although patients want to be seen as quickly as possible, they would much prefer someone who is considerate and really empathetic with their situation rather than just getting them out the door as quickly as possible. And it also includes a discussion forum for staff so that they can reflect upon their experiences and the day-to-day problems of working in such a busy environment. So the third strand of our solutions is the Toolkit. So this provides free high-level design recommendations to inspire or encourage healthcare providers to make some quite simple changes to the environments to make them a bit more comfortable for patients. And this was developed from our research where we were looking at healthcare providers and people who had implemented changes that improved the care environment. And we compiled these recommendations and broke it down into the key areas of the patient journey. And these were all in practice at other NHS trusts. So they aren't necessarily solutions in themselves, but specifications or service changes that trusts can make as and when they have money or feel encouraged to do so. It's intended to be used by NHS staff, but also architects or interior designers, people who are designing a new healthcare facility. But since this is available online as a resource, we decided to really focus on the people and the guidance solution. So in 2012, they were installed and piloted at 2 hospitals in England, Southampton General Hospital in Southampton and St. George's Hospital in London. So we worked closely with these trusts throughout the implementation process and to customize our designs. So we still have a lot to cover under implementation and delivery, but I think we're going to stop here today and just give you a quick little recap of everything. And tomorrow we will pick up so you can see the solutions installed at trusts and where we've gotten to, as well as the evaluation process and how we undertook that.
We have now completed our double diamond process. So we've demonstrated that it is an iterative process that begins with identifying the problem and carrying out the necessary research. So this exploration at the beginning of the process then converge at the end of the design phase when the objectives need to be really clear. The design process begins actually during the develop phase, which diverges again into an iterative process that requires the design to be tested again and again and refined before the implementations. So we then have to work to synthesize all of these informations and feedback we had, explorations, interviews, into a final result that could be then shared with everyone.
How did we start with prototyping? How did we show this? And how did we do our user testing? So prototyping really began just sketching on paper. It's a lot of Post-its generally. So it was really writing out the entire patient journey, and then it was translating that from something quite physical into something digital on the computer. So the very first stages of the process map, that was really the beginning of our prototyping. And it's a lot of doing that on the computer, printing it out, having a look, marking on it, redoing it. It's an interesting relationship between the computer and printing it out. Oftentimes on screen it looks fine, then you print it out and look at it from a distance and you immediately realize stuff that is quite difficult to read, or maybe what doesn't work once it's actually physical. And then user testing was very informal. We printed out sheets of A4 paper and took it out on the streets. We had developed a little questionnaire and just asked people to look at our process map and say, does this make sense? What do you think this icon means? Do you understand this? And just getting feedback in that way. It happens quite quickly. In a day, sometimes you might have, if you have 2 or 3 different people working on it, it's coming together and then revising, and then from there moving forward. Sometimes you have something to really focus on that you then work on for a week, and it's just minor tweaks. Unfortunately, it happens so fast and so quickly. Images are kind of hard to, it's very hard to visualize that for people, but you could see from the very beginning slide much of our studio, which just has stuff pinned up everywhere. And it's a lot of mocking up and looking at that and getting feedback from everyone.
So I guess that's it. So thank you for listening, and I guess see you all tomorrow.